Hi, my name is Terry Duran, and today we're going to be talking about managing disruptive behaviors. The objectives of this course are to define the main components of the ABC approach to care as it has to do with disruptive behaviors. We're also going to give examples of common antecedents or triggers of disruptive behaviors. We're going to give examples of common automatic reactions to these behaviors. And we're going to describe the relationship between behavioral symptoms, antecedents, which can also be called triggers, and consequences and reactions. We're going to also develop a plan of care for a person utilizing the ABC approach. And we're also going to be discussing crisis intervention techniques that may be used to calm and redirect a person who is intensely upset and may feel threatened. Because a lot of the residents with disruptive behaviors have dementia, I want us to look at this old versus new culture of care. Now, this can be generalized, but it also can be used in looking at dementia. So the old culture focused on illness orientation, these lost abilities and what the person cannot do, this disability that is caused by dementia. The new culture is person-centered and focuses on retained abilities, what the person still can do, the strengths, their interests, their skills, their long-standing traits, abilities, preferences, experiences, and habits. The old culture, as far as attitudes, states that nothing can be done. It's incurable and there's no hope. The new culture is person first. Again, we talk about things being person-centered. That means that there's continued meaning in living. The ability to enjoy life is retained. The old culture, as far as behaviors, is that everything is caused by the disease. The new culture understands that there are brain changes that are taking place, and it really depends on the type of dementia, the part of the brain affected, and the actual stage of disease, and how this relates to other things like unmet needs, the residents' long-standing traits and habits, their environmental factors, and stress. Their behavior is communication. It signals discomfort or distress or the need for assistance from caregivers. The old culture labeled. So you would hear negative terms for behaviors. The resident is disruptive, difficult, aggressive. You would hear these negative terms for the person. They're a hitter or they're demented. The new culture sees behavior as a symptom of a disease. For example, the behavior and psychological symptoms of dementia or need-driven dementia compromised behaviors. So these are behavioral symptoms or just behaviors. Again, we're person-centered. It's the person with dementia or just person. The old way of intervening is to manage behaviors, control the person who is likely to cause trouble, to contain behaviors, disallow negative influence on others in the environment. The new culture of care understands and responds versus managing or controlling. It problem solves about the meaning of the behavior, like why here, why now, who has the problem. It promotes function and comfort, and it engages in pleasurable activities, and it focuses on trying to distract and reassure and to comfort the person. Examples of some disruptive behaviors that you need to watch for would be apathy and depression. Now, you would ask, why apathy and depression? Well, you would want to watch for things like suicidal ideation or suicidal tendencies. Also, wandering and elopement risk. Elopement would be basically when somebody would leave the long-term care residence, kind of escape the long-term care facility. Repetitive behaviors, anxiety, sleep disturbances and sundowning, aggressive language and behavior, sexually inappropriate behaviors, and hallucinations, delusions, and psychoses. You always need to look for an underlying cause in the behavioral symptom. For example, is there a medical problem or the onset of an acute illness that needs to be treated? For example, new onset confusion in somebody who doesn't have dementia, or an overlapping psychiatric illness like depression that is causing excess disability that needs to be evaluated and treated. Or maybe in your dementia patients, this can be something simple like batteries needed to be replaced in a hearing aid, or glasses that need to be replaced or refitted to assure accurate sensory input to avoid misinterpretations and misbeliefs. There are many medications that we've talked about in other modules that can cause adverse consequences that are observed in behavioral symptoms. And we've talked about in other modules about the Beers criteria. This criteria ensures that patients or residents are not being prescribed certain medications that can masquerade as dementia or that can cause behavioral symptoms. So always we need to look at their medications and make sure that they are being appropriately prescribed and that they are not on the Beers criteria. There's also some temporary but still distressing biological tension, like hunger. Is somebody simply hungry? And this, of course, would be more in your dementia residents. Are they thirsty? Or importantly, are they in pain? And is this contributing to the behavioral symptoms? Or are there unmet psychological needs like loneliness, boredom, or longing for things now lost to the person? For example, their home, loved one, pets, involvement in meaningful activities. This can also make a huge contribution to behavioral symptoms. In dementia, behavioral and psychological symptoms most often signal distress and discomfort to the person who experiences them. And this behavior is a red flag to pay attention. And the individual is not trying to upset, frustrate, or annoy the caregiver. Instead, the behavior can be seen as communication. And we just need to figure out what that message really is. The primary point that caregivers should try to keep in mind at all times is that, especially in dementia, which is where you will see many of these disruptive behaviors, and I would say the majority, is that the behaviors are not purposeful. The losses associated with dementia, which are progressive brain disease, cause a long list of challenges for the individual. And these are compounded by the way caregivers approach the resident, other sources of stress and disability, and what is going on in the environment. Unfortunately, sometimes we can get into this cycle of mutual distress Not only does the resident have problems that continue to go unresolved, compromising their quality of life, but caregivers also suffer from feelings of frustration, incompetence, anger, and resentment. And those feelings and perceptions and labels contribute to a downward spiral in care. So residents can be given a label of being difficult, hard to manage, or even aggressive. The caregivers attempt to change the person's behavior, not necessarily what they do as a caregiver. And then the resident is just labeled again, a problem person. They're impossible, they're mean, they're unappreciative, they're manipulative, they're a pain. And no new interventions are tried because the resident is the problem. And caregivers cope by ignoring or avoiding the person. The resident is not comforted or assisted, and behaviors become more intense. Caregivers feel even more distressed and frustrated by the behaviors. Caregivers can even avoid, ignore, or even fight back. And then the behavior continues and often becomes even more intense. And around it goes, and nobody wins. Before we actually get into learning about the ABC approach, there's a few things I want us to look at before we start. Number one is we need to look at the resident with the behavioral symptom as a person who has the same basic human needs as everyone else, who gets hungry, tired, lonely, bored, who feels pain related to chronic medical conditions like arthritis or joint disease, who has sensory changes that may interfere with seeing and hearing things accurately, and who has lived a long and full life filled with unique experiences. This is a person first, as a human being that has preferences, habits, personality traits, and interests, just like everyone else. When I worked in long-term care as a nursing assistant, there was a resident that had had a stroke, and he never spoke. We would turn him every 2 hours. We would clean his bottom. We would change the incontinence pad. And one day I was too lazy to warm up the water. And when I cleaned his bottom and changed the incontinence pad, he said, all of a sudden, clear as day, "That's cold." And I had never looked at that man as a person, and I'm ashamed to say it today. So we need to see the residents as people. Second, we as staff can change what we do. And I hope that you see that by the end of this teaching. Also, facility-related factors can create a context of care that may contribute to the occurrence of these behavioral symptoms. The social environment may either create opportunities or provide negative and restrictive feedback that fosters the development of behavioral symptoms. So facility-related factors and staff approaches have an enormous impact on the occurrence of behavioral symptoms. So as we get into the ABC approach to behavioral management, there are several goals. Number one, prevention is the best medicine. Number two, we need to identify the individuals who are at risk for developing behavioral symptoms. Number three, learn to recognize behaviors that signal that the resident is uncomfortable or threatened. Number four, we need to intervene early to diffuse the situation, keeping the person calm and comfortable. And number five, we need to create an environment in which the behaviors are unlikely to occur in the first place. The ABC approach is not a single step, but is a continuous process of assessing the person with the behavioral symptom and adjusting interventions, evaluating care, and starting again. And there are three main things that we want to assess and then try to adjust in our intervention. So these three things are the A, which is antecedents. So the events or factors that precede the behavioral symptom and contribute to its occurrence. Antecedents can also be called triggers because they set off the behaviors. The B is for the specific behavioral symptom that is of concern. So looking at one behavioral symptom at a time in the problem solving and care planning process. C is for the consequences, things that happen after the behavior occurs. That includes all the reactions and responses to the person, including those by other residents, family, visitors, volunteers, and staff caregivers. So let me explain it a different way. We basically look at the behavior. It can be aggression, it can be anger, confusion, frustration, delusions, hallucinations, etc. But we look only at one behavior. Now, what triggers this behavior before? Is there anything that we can do beforehand to eliminate or minimize the trigger so that we can eliminate or minimize the behavior? But if the behavior is triggered, then how can we respond to it? And then what are the consequences? And then again, how can we care plan again and again to minimize the trigger, etc., etc. So when we are trying to reduce or eliminate behavioral and psychological symptoms, there are things that we can do to prevent or minimize the risk that the person will feel threatened by our actions, become fearful or uncomfortable, and show that discomfort in challenging behaviors. By understanding situations in which behaviors occur, we can begin to anticipate the problem and use preventative methods, understanding what is really happening and why. And this relies on accurate assessment. Prevention requires that caregivers know the person and the situation well. To assess well, you need to think like a detective. So get all the facts, observe, listen, read, ask, stop and question the behavior. Look for clues about what is going on and why. Listen and talk to others to get the whole picture and get everyone involved in the assessment. And pay good attention to the person and his or her behaviors. When care planning, describe the behavior in detail. What is the real concern? What is the resident doing? Where is it happening? How often does it happen? How long does it last? And does it seem to get worse over time? Who is it really a problem for? The resident, the family, the staff, or even a certain member of the staff? Is the behavior safe or is it dangerous? Are our expectations realistic? Are the residents' or family's expectations realistic? Are we or the family or the roommate or whoever wanting more from the resident than is practical given their limitations? Identify possible antecedents or triggers. Where does the behavior occur? What else is going on around the person? Who is there? What are they doing? What is going on in the environment? Has the person had a change in status? For example, as we talked about in other modules, a physical or a mental or a social change in status? Did someone just say or do something to the person, maybe with dementia? Did the behavior occur while trying to provide personal care? Does it happen at a certain time of day? And what might be going on inside of the resident? Antecedents. Now these, again, are events or even factors that precede the behavioral symptom and contribute to its occurrence. Antecedents are also called triggers because they set off behaviors. So when we look at factors that precede the behavioral symptom, the resident could have cognitive impairment, which would basically mean dementia. So what type of dementia does the person have? What stage of the disease are they in? Are they in early, middle, or late? And what is their baseline level of function? What can they do when provided the right type of assistance? Another antecedent or factor could be psychiatric illness. What are they thinking or feeling that might be causing this behavior? Are they actively hallucinating? So seeing or hearing something that we do not? Are they responding to those hallucinations? Or are they experiencing upsetting or frightening delusions? So this could all be of course, in dementia also. So delusions are false or fixed beliefs. Do they think you or someone else is out to get them? Are they acutely confused due to a medical illness? Are they depressed, which is associated with increased behavioral symptoms, also within dementia? Sensory impairment can also be a factor. Is the person seeing, hearing, or understanding what is going on? Is there enough light to see? Are they misinterpreting their environment? Is that misinterpretation contributing to misbelief that is part of the problem? What do they see, hear, and feel? What possible misinterpretations may be contributing to anxiety or fear, like thinking someone is spying on them when they see their own reflection in a dark glass? Other factors would be unmet biological and psychosocial needs. So is the resident in pain or discomfort? Is the resident hungry or thirsty? Does the resident need human contact or touch? Is wandering an expression of a need for exercise? Does the resident need to use the restroom? Is the resident lonely? Are they seeking companionship? Are they missing a friend, a family member, a pet? Do they need someone to talk to? Is the resident bored? Do they need a meaningful activity? Are they missing a favorite activity or pastime? And what were those activities? Also, an antecedent or a trigger could be the level and type of stimulation. So what is going on in the physical environment? Is it too noisy or is it too confusing? Is it too cold or busy or dark or crowded? Is the behavior related to television or radio that they do not understand? Does it occur in large public areas like the day room, the dining room, or activity room that tend to be busy or overstimulating? Do certain people seem to trigger the behavior? Does it seem to happen when the family is there or after certain outings or activities? Has there been a lot of change in staff caretakers? Is it worse or better when certain staff are working? And also health conditions. What medical conditions does the resident have? Has there been a change in that condition? Does the condition cause or contribute to pain? Does the person have an acute illness that is causing acute confusion? Has the person been prescribed a new medicine recently? Is the behavior related to an adverse reaction or toxicity? And is the medicine interacting with another medicine the person is already taking? Facility routines and characteristics. Is the behavior related to certain facility routines like rising, going to meals or activities, bathing, or bedtime? Does the behavior tend to occur in large group activities? Is it a response to certain people? So people at the dinner table, maybe particular residents, or even certain staff members? Does it occur in certain locations, such as the shower room, or during particular daily activities, such as dressing? Is the person misinterpreting factors in the physical environment, such as long corridors, dark windows, mirrors, shined floors? I remember there was a resident that when I worked in long-term care, and he would become very agitated when we tried to toilet him. I believe it's because we were women and he did not want us seeing his private areas. So I decided that it was easier for me to clean up the bathroom than to have an agitated resident. So basically I was like, okay. He would go and I would clean up the bathroom. And that's basically what we did. So antecedents or triggers can also be our responses to the resident's behavior. So are we asking them to use a skill that is lost? So as far as dementia residents, they slowly but surely lose skills. It's a progressive disease. So they will continue to lose those skills. So are we asking them to use a skill that they are slowly losing? So dressing without being cued to put clothes on in a certain order, or taking the person by surprise, not in the person's visual field, or we failed to make eye contact before touching or speaking to the person and they became startled. Maybe forgetting to explain what is being done and why, or using language that is too complicated for the person to understand, or trying to reason with the person's misbeliefs. Now, this would happen with my grandma. She would become agitated because the horses weren't fed. So instead of trying to reason with her, I would simply say, Grandma, everything's okay. We fed the horses. Being hurried and doing things to the person instead of breaking tasks into steps and cueing them to be independent. Using "you are wrong" messages. For example, that is not your room. That does not belong to you. No, you cannot go home. You live here now. Or labeling resistance. So for example, if the resident pulls back, avoids, or pushes you away, or another behavior that communicates that they want you to stop. Maybe there's touch or invasion of personal space, frustration related to the resident's declining abilities, a loss of personal control or choice, or a lack of attention. Consequences are what happens after the behavior occurs. Now, consequences include all the reactions and responses to the behavior by staff, family, visitors, volunteers, and residents of the care setting. Most reactions and responses are not planned. They just happen. However, these consequences often affect the behavior. So there are 3 reactions that people can have to certain behaviors. They can allow low-level behavior to continue, hoping that it will just go away on its own. Or they can allow it to increase, like telling the person, no, you can't do that, stop it right now, which is a form of negative and restrictive feedback. Or, which is the right answer, they can help to reduce or eliminate the behavior by looking for possible unmet needs and responding in a way to calm and comfort the person. So the questions that we can ask: what happens after the behavior occurs? Who responds or reacts to the behavior? The staff, other residents, family, visitors? What is said in words and non-verbally? How do people look, sound, and act? What does the person with the behavior or dementia do next? What automatic reactions or consequences make it worse instead of better? What are the alternatives? What other reactions and responses are possible? What might be said or done to comfort, reassure, or redirect the person? So common unhelpful automatic reactions would be avoiding or ignoring the person or their family, becoming defensive in our words or actions, trying to pay them back by forgetting or being slow to answer their calls or respond to their requests, being indifferent, cold, or silent, which says, I don't care about you. You are not even worth paying attention to. Feeling angry at, resentful about, and frustrated by the resident. Blaming the person, thinking that he or she is doing it on purpose and could stop if he or she only wanted to. Again, allowing low-level behavior to continue, hoping it will just go away on its own. Trying to correct or set limits with the person, telling the person, no, you can't do that, stop it right now. Setting the person up by expecting them to remember what we tell them. For example, lunch is in an hour, I'll be right back. Increasing the person's level of frustration or anger by trying to rationalize with them, especially in response to misbeliefs or delusions. And threatening the person with facial expressions, gestures, or our tone of voice. We all have moments when we'd like the resident to stop right now or to change overnight and become a model resident. Of course, that's not realistic. Instead, we need to develop a goal that is based on the resident's real-life skills and abilities. And we can only deal with one behavior at a time. So we need to make a plan. And step 1 is to set behavioral goals. So can we eliminate the behavior? Or can we decrease the frequency? Do we need to adjust our own expectations? What do we really want the resident to do? Is that goal realistic? Is it specific enough that we'll know when it's been reached? Is it a single step, or do we need to break it down into little pieces to get the job done? And do we need to adjust our expectations. Once we decide on a reasonable and achievable behavioral goal, we need to look at the list of possible antecedents or triggers. What can we add or subtract to reach the behavioral goal? Which antecedents or triggers can be eliminated or changed to reduce their negative impact on the person? What new cues can we add to encourage functional behavior and comfort for the person? Does the resident need a rest period so that they don't sundown in the afternoon? Should the resident be allowed to eat in their room to avoid the noise and confusion of the dining room? Would it help to take down pictures to reduce the psychotic resident's delusion that their parents are alive? Finally, we need to think carefully about consequences and how we can change our reactions to the behavior. Think about all those things that may keep the behavior going and fuel the fire. Which consequences or automatic reactions can be eliminated or changed to reduce their negative impact on the resident? What new, neutral, or positive responses can we add to encourage functional behavior and comfort for the resident? Adjust interventions to fit the resident's ability to understand and use information. Speak in simple, easy to understand language. Give one command or ask one question at a time. Wait for a response and listen carefully for meaning. Don't try to reason. Monitor your tone of voice, facial expressions, and body language. Reduce environmental stress to calm the person. Remove unnecessary people or turn off the TV or move the resident to a quiet place like their room. Don't confront or challenge delusions or hallucinations. Try to distract them to some other activity or topic and reassure them that they are safe with you. Try to reduce misleading stimuli. So remove pictures or objects that lead to misperceptions. You may need to turn off the TV or the radio. And check for internal stressors that may be contributing. Are they hungry? Are they tired? Are they uncomfortable? And then we always need to evaluate how we're doing. We have to constantly look at both our successes and our failures and ask ourselves what happened and why. Did the plan work? Did any part of it work? Why or why not? What got in the way and what made the difference? So again, to summarize, once we have our assessment information, we're ready to develop an action plan. That means we're going to look for the interventions that will help reduce the behavioral symptoms and increase healthier, more adaptive, and comfortable behavior. So remember, step 1, set behavioral goals. Step 2, add or subtract triggers. Number 3, change consequences, add positive and reduce negative. And number 4, evaluation. Did it work? When we discuss managing a crisis, one of the definitions of crisis is a time of intense difficulty, trouble, or danger. I want to clarify that I am only discussing a time of intense difficulty here, not when a resident or a staff member's health or well-being is in danger. Now, in that case, law enforcement, emergency services, or mental health professionals will need to be called. Now, under the definition of intense difficulty when dealing with disruptive behaviors, a crisis can never be fully predicted. But what we can do is organize approaches to best meet the needs of those individuals who experience a crisis. So the very first thing that needs to be done is we need to tune into our own attitudes and feelings about what is going on. Understanding that getting angry won't help and will probably make things worse. So remember that being caught off guard puts you at risk for fueling the fire. For example, the first time it happens and you fight back versus assessing and problem solving through the crisis. Likewise, if you are angry or if you are resentful about past experiences with the same individual or the same resident, you probably won't be effective. So try to remain calm, cool, and collected, at least on the outside. Use positive self-talk to get yourself under control. For example, remind yourself, this person is uncomfortable and needs my help. I can handle this. I don't need to get upset too. They're not really angry with me. They're just upset that I'm in the way. And I will add here that you need to understand, especially with the person with dementia, that it's not really that person. It is the disease process that they are going through. Also, avoid words or actions that might threaten the person even more. And if you can't get your own feelings under control, leave the area immediately, alerting other staff if needed. Keep track of what you are doing with your body and what that might mean to the person. So don't surprise them. Move slowly and steadily. Keep your hands out where they can see them. Palms up and open, which is non-threatening. Respect their personal space. The more threatened they are, the more distance you should have between you and them. Don't stand squarely in front of them, which is very confronting and threatening. Turn slightly to one side. And be careful to not stare, glare, or otherwise challenge the person with eye contact. Don't turn your back to the person and always leave yourself an escape route. Avoid standing over the person if they are sitting or reclining, which again can be very threatening. Think about what you say and how you say it. So speak in short, simple phrases. Use a normal tone of voice and talk at a normal rate. Communicate concern and caring. And avoid sarcasm, insulting remarks, and even humor, which can be misinterpreted. Use directions or explanations that are appropriate for the resident and the situation. For example, I'm sorry if I upset you. That wasn't what I meant to do. Or, how can I help you be more comfortable? Mr. Smith, let's go to your room. Or, for example, a quiet place. Or, it's all right now. You're safe with me. I won't let anything happen to you. Listen carefully to what they are saying and try to respond to the message they are trying to communicate. So check for meaning. For example, you're saying that, or avoid giving advice. Respond to the content of their message, so the actual meaning, not the way it's being said. Try to understand what they're upset about. Respond to that unmet need or feeling. Don't assume that they have heard or even understood you, especially in dementia. Our focus becomes very narrow when we are anxious. Try to calm or soothe them, remembering that the first priority is to protect yourself and others. Leave the room or area if they continue to threaten you. And then, of course, get physical assistance even if you aren't sure you really need it. Use physical control only as the last resort. Try everything else first. So this would be an example of the ABC approach to behavioral management. Remember that we focus on one behavior at a time. So this example is focusing on aggression. And we see our antecedent, our behavior, and our consequences. So focusing on the antecedent or the trigger, we want to see what was happening before the behavior began. And we're focusing on Mrs. B. So in Mrs. B's case, personal care was usually delivered right after breakfast. Now, she usually falls asleep in her chair in the dining room, and staff quickly wheel her back to her room for her morning care. But staffing has been short due to illness. She also has arthritis, but there's no recent pain assessment in her chart. Mrs. B's abilities to verbally communicate have declined since the fall. So as far as behavior, so we just described what was happening before the behavior began. But we want to describe the behavior in neutral, clear terms, focusing on one event at a time. So during the last 3 days, Mrs. B repeatedly calls for help, shrieks loudly, and pinches staff during personal care, especially toileting, bathing, dressing, and positional changes. So let's look at our consequences. What happened in response to the behavior? What happened next? What did the staff do? How did the resident respond? And who was affected? So another staff member came to hold her down her hands to permit completion of personal care. The staff member has 2 small areas of broken skin from scratching and a 1 by 2 centimeter scratch on the left forearm. The staff feel frustrated and they dread giving her care, and other residents upset by screaming and calls for help. So how can the care plan be changed? So delay personal care until after breakfast, until Mrs. B just awakens naturally. Maybe provide breakfast in bed so Mrs. B can doze more comfortably afterwards. This is a huge one. Assess for pain prior to care and provide analgesia as needed. Also, if a patient has had a fall, in this case, I imagine they have fully assessed the fall. But if they're having so much pain and reacting, and the fall was only 3 days prior to that, you would surely want to assess for some type of fracture or sprain or something like that. Also, speak slow and clear prior to initiating care. Provide soft cloths to hold during care delivery and occupy hands. Continue to monitor and document behavior during care episodes for the next 7 days, and describe changes in behavior, including evidence of decreasing intensity, frequency, duration of behavioral events. Also, maybe seek a partner for caregiving prior to event. Agree on the care approach. Maybe think about giving some type of analgesia, so a over-the-counter pain medication 1 hour before her bath. And maybe one person can occupy Mrs. B's time and talk to her about personal information, maybe her life story, to occupy her attention. and loosely hold the outside of her hands as she holds the cloths. So basically, you just have to try different things and see if they work. If they don't, you go back to the drawing board. So that would be an example of the ABC approach to behavioral management. There are also many different forms that you can use to document. So these are just a few of the many examples that you can find online that I just wanted to show you. Now, the other thing I did want to mention is that the ABC approach is used for in many different settings. It is used in child psychology, it's used in the school setting, but this approach is one that has been developed for the long-term care setting.